Imagine facing a clinical scenario where you're sitting in an exam room and you are told that you likely have an aggressive, highly lethal mucosal melanoma.
Wow, yeah.
If
That's a completely terrifying moment for any patient.
Right. You are instantly bracing for radical surgical excision. The anxiety is just crushing.
Unimaginable, really.
But then, just a few weeks later, a specialist looks through a handheld polarized lens and realizes that the initial chaotic presentation, the thing that looked so much like cancer, was actually just the superficial aftermath of severe scratching.
Right, just physical trauma.
Exactly. And beneath that trauma is not cancer at all, but a chronic autoimmune condition.
Which is a massive pivot. Going from oncology to managing an autoimmune flare-up.
It's a pivot that completely changes a person's life. And today, we're exploring exactly how that happens. Welcome to the deep dive.
Glad to be here.
So, our mission today is unpacking a stack of dermatological studies and clinical guidelines to answer this really highly specific, cutting-edge question. How are specialists utilizing dermoscopy in the clinical evaluation of early vulvar lichen sclerosus, or, VLS for short?
And, the stakes underlying that specific question are just immense for the listener to understand.
Yeah, lay it out for us. What exactly is VLS doing to the body?
Well, VLS is this immune-mediated inflammatory disease.
Hmm.
And it is characterized by intense pruritus, really severe itching pain, and a progressive destruction of the local tissue.
And if it's not caught early, it gets pretty devastating,
That's
right?
extremely. If it isn't intercepted early, it leads to permanent architectural scarring of the genitalia. We're talking about complete resorption of the labia minora.
Oh, wow.
Yeah, or midline fusion. And on top of that devastating impact on, sexual function and overall quality of life, there is this persistent risk of malignant transformation.
It can actually turn into squamous cell carcinoma.
Exactly. So the entire objective for clinicians is intercepting the disease before that irreversible structural damage occurs.
But the hurdle with intercepting it early, and this is what our sources really highlight, is that the diagnostic landscape in those initial stages is incredibly murky.
Oh, it's a minefield.
Because a visual inspection with the naked eye often just yields this, non-specific redness, or just a really subtle textural change.
Right, it mimics a dozen other localized inflammatory responses. Yeast infections, contact dermatitis, you name it.
So the traditional clinical reflex is to rely on histopathology. You take a biopsy.
Which makes sense on paper.
Sure, but the sources point out a massive vulnerability there. In early VLS, even the histopathology can be entirely nonspecific.
Yeah, and that's the scary part. The characteristic cellular changes simply haven't formed yet.
The tissue hasn't scarred enough to look like VLS.
Exactly. A pathologist looking at an early punch biopsy under a microscope might just report a generic lichenoid inflammatory infiltrate.
Which means basically nothing, just there is inflammation here.
Right. So the clinician is left in this gray area. They suspect VLS based on the patient's severe itching. But the naked eye in this, that's a perfect analogy, actually. The glare hides everything beneath the water.
But by polarizing the light, like putting on polarized sunglasses, the specialist can optically penetrate that surface layer.
Yes. And suddenly they can visualize all the structural and vascular formations in the deeper epidermis and the epidermis.
So let's focus on those vascular formations, because the way the blood vessels behave in early VLS was, I think, the first major counterintuitive finding in these studies.
Oh, it totally throws you off if you're just thinking about basic biology.
Right, because when I think of localized inflammation, like a histamine reaction, contact dermatitis, any acute flare-up, the physiological response is vasodilation.
Increased blood flow rushing to the site.
Exactly. So logic suggests that an inflammatory condition like early VLS would present under the dermatoscope as this chaotic, massive overgrowth of blood vessels, just red everywhere.
That assumption makes total physiological sense. Yet the dermatoscope reveals a stark departure from that norm.
What does it actually look like?
Well, one of the most consistent dermoscopic hallmarks of VLS is a significantly decreased overall vascular density.
Wait, decreased? Compared to unaffected skin?
Yes. The overall concentration of visible vessels drops dramatically. It's pale. However, the vessels that do remain exhibit profound polymorphism.
Meaning they take on mixed, highly irregular architectural shapes instead of a nice, uniform network.
Exactly. They lose their organized, predictable structure. You'll find scattered linear vessels sitting right alongside branching telangiectasias.
And it's all arranged asymmetrically.
Very asymmetrical. But within that irregular presentation, there is one specific vascular formation that serves as a vital, highly time-sensitive diagnostic clue.
The dotted vessel.
The dotted vessel. In a major retrospective analysis highlighted in our sources, these dotted vessels were identified in roughly 45% of early VLS cases.
I really want to break down the mechanics of why a biological tube of blood appears as a static dot under polarized light. Because obviously, it's not actually a sphere of blood in the skin. It's about the anatomical orientation, correct?
It is entirely about the orientation. So in the early inflammatory stages of VLS, these tiny blood capillaries become dilated, and they get trapped immediately beneath the basement membrane zone.
Okay, so they're stuck.
Right. And because these capillaries are dilated and pushing vertically upward toward the surface of the skin, the dermatoscope, which gives you a top-down two-dimensional view, only captures the absolute apex of the vascular loop.
So it's like looking straight down the barrel of a tiny capillary.
Exactly like that. You're looking down the pipe, and visually it registers as just a pinpoint red dot.
So the clinician scanning the mucosa sees this pale, low-density vascular landscape, but it's punctuated by these specific vertical capillary loops.
Those dots are the alarm bell for early VLS.
But the sources are really emphatic about the timing here. These dotted vessels, they pull a disappearing act, don't they?
They absolutely do.
If the evaluation happens too late in the disease progression, the dots are just entirely absent from the dermatoscope's field of view.
And the absence of those vessels in later stages tells us an important story about the pathology of how the disease progresses.
What's happening to them?
Well, as VLS advances past the early window, which is generally defined in the literature as the 2-year mark, by the way, a profound dermal fibrosis begins to dominate the tissue.
So heavy scarring.
Yes, severe sclerosis, and what we call hyalinization of the dermal collagen.
I was trying to conceptualize that hyalinization process when reading the studies. If we imagine the normal, healthy dermal collagen as this flexible, loosely woven net that safely houses and supports all those tiny capillary loops.
Right, a nice flexible net.
Early VLS is basically the process of those individual threads in the net swelling up with inflammation. And as the disease progresses, those collagen threads fuse together.
They do. They stick together completely.
Turning that flexible net into a dense, rigid, impenetrable sheet of plastic. It's like pouring concrete over a freshly paved road.
That is a highly accurate biological translation, actually. The hyalinized collagen literally overtakes the vascular architecture.
So the capillaries are still physically trapped underneath. Right?
They are. But that newly formed hyalinized plastic shield, the concrete, is entirely opaque. It creates an impenetrable visual barrier.
Wow. So if a clinician is performing dermoscopy on a patient who has been suffering for 3 or 4 years...
Those superficial dotted vessels have been completely buried by the dense, scarred collagen. The dermatoscope just cannot see through the fibrosis.
Which isolates perfectly why this tool is deployed so aggressively at the very first report of symptoms.
It is a literal race against the fibrosis. Catching those dotted vessels is the difference between initiating potent topical steroid therapy to halt the hyalinization versus merely managing the irreversible architectural damage after the fact.
So the clinical window is really narrow. But the sources also say that even when a patient presents later, or if the hyalinization has already begun to mask the vascular network, the evaluation doesn't just hit a dead end.
No, it doesn't, because the fibrosis itself forces a whole cascade of other structural changes on the surface of the skin.
The clinician just has to shift their focus.
Exactly. They shift away from the vascular fingerprint and start looking for non-vascular structures.
And the dermatological terminology used to describe these secondary structures is just remarkably evocative. I mean, the sources detail a background canvas of milky pinkish areas interrupted by comedo-like openings and ice slivers.
They're very visual language.
It is. So let's connect those visual descriptors to the histopathological reality. Starting with that milky pinkish canvas, that is essentially the visual manifestation of the melted plastic net we just talked about, right?
It's the direct reflection of the pathology. Regardless of the disease stage, the most persistent dermoscopic feature of VLS is the presence of these structureless yellowish-white or milky pinkish areas.
Set against a diffuse whitish background.
Right, because under polarized light, healthy skin usually displays a really delicate reticular network. But in VLS, that dense, sclerotic hyalinized collagen acts like a dense mirror.
It reflects the polarized light back as a blank, pale, structureless void.
Exactly. That void is the fundamental canvas of the disease.
And breaking through that pale canvas are what the sources call the comedo-like openings. Now, a comedo usually implies a follicular blockage, like acne,
It
right?
does, yeah.
How does that mechanism translate to a mucosal surface affected by VLS?
The visual is similar to acne, but the mechanism is driven by the localized destruction of the autoimmune disease.
Yeah.
On the dermatoscope, these appear as tiny circular white or yellowish plugs.
Okay.
Histologically, they represent follicular or adnexal structures, so pores and glands, that have become profoundly hyperkeratotic.
Meaning they're producing way too much keratin.
Yes, the appendages are basically being choked by the surrounding inflammation and sclerosis, causing them to plug up with dense keratin and cellular debris.
And the data points out that these comedo-like openings are heavily concentrated in early lesions.
Very heavily. As the disease advances into late stages and the epidermis severely atrophies and thins out, these structures become much less frequent.
But there's also a mechanical reason a clinician might miss them during an early evaluation, isn't there? Driven purely by the anatomy of the region.
Oh, absolutely, the friction factor.
Right.
The anogenital region is subject to constant natural mechanical friction, just from walking, wearing clothes. And because these hyperkeratotic plugs are so superficial, they can simply be rubbed away before the patient ever reaches the examination table.
So finding a comedo-like opening is a robust diagnostic indicator, but its absence doesn't mean you're in the clear.
Not at all. Its absence does not clinically rule out early VLS.
Then we have the ice slivers. These are described as bright white, linear or triangular shards sitting on the surface.
Yeah, burst ice structures.
If the comedo-like openings are circular plugs, what mechanical force is creating shattered glass on the skin?
Well, these ice slivers represent an even more extreme variation of hyperkeratosis. Instead of just a localized follicular plug, you have dense, irregular scaling and profound hyperkeratosis of the stratum corneum itself.
So the whole top layer is scaling up.
Yes, often tethered to the underlying structures. And the polarized light catches the edges of these dense keratin shards, making them appear brilliant, white, and angular against that dull, milky background.
It provides such a layered understanding of the tissue without making a single incision. It's incredible.
It really is.
But it's not a purely monochromatic presentation either. I mean, the skin also holds a visual record of its own trauma. The sources highlight peppered dots that are blue-gray alongside purpuric red and purple spots.
And colors tell a whole different story.
I really want to dig into the blue-gray peppered dots because the biological mechanism there, the way the inflammation alters the pigment, is just wild.
Oh, it relies on a process called pigmentary incontinence.
Which sounds so strange.
It does. But in early VLS, the aggressive lichenoid inflammation attacks and disrupts the basal layer of the epidermis, which is exactly where the melanocytes, the pigment-producing cells, reside.
Okay, so the factory is under attack.
Right. And as that basal layer breaks down, the melanin pigment essentially drops like a sinkhole into the deeper dermis.
The pigment just falls out of its normal anatomical zone.
It falls right through the floor. Once it drops into the dermis, local immune cells, called macrophages, arrive to clean up the damage. And they phagocytize, or essentially engulf, the loose pigment.
They eat it up.
Exactly. We call these pigment-loaded cells dermal melanophages.
But melanin is brown. Why do the sources say these dots look blue-gray?
Ah, that is the Tyndall effect.
Yeah.
Because that melanin is now sitting much deeper in the tissue than it should be. The optical physics of the skin change, the way the light scatters as it travels back up through the tissue, makes that deep brown pigment appear blue-gray to the clinician's eye.
Wow. So it is a literal footprint of the inflammatory attack.
Yes, preserved in the tissue.
And the purpuric red and purple spots, those have an even more direct mechanical origin, don't they?
Very direct. The purpuric spots are straightforward microhemorrhages.
From the scratching.
Right, because VLS induces such agonizing, unrelenting pruritus. The patient's natural response is intense scratching. The skin is already compromised and atrophic from the disease process, so it tears microscopically.
And blood pools in the superficial layers.
Which presents under the dermatoscope as irregular red or purple splotches.
Which brings us perfectly back to the clinical case study we opened with, the 59-year-old woman.
Ah, yeah.
Because it was exactly those purpuric spots, those microhemorrhages, combined with the pigmentary changes, that triggered such a massive clinical alarm in her case.
Let's synthesize the clinical application using that exact case. So the patient presents with a newly onset, highly pigmented, asymmetrical lesion on the vulva.
And to any experienced clinician, a spontaneous, chaotic, darkly pigmented mucosal lesion dictates an immediate mandate.
Rule out melanoma immediately.
And the initial dermoscopy supported that fear, didn't it?
It did. They observed a completely disorganized architecture with a massive hemorrhagic component. The standard protocol for suspected mucosal melanoma is swift, wide surgical excision.
I mean, the psychological toll of that impending procedure on the patient, you can't even imagine.
Absolutely terrifying. But the clinical timeline afforded a short delay before the surgical intervention could happen.
And when the patient returned for a follow-up dermoscopy just a few weeks later, the presentation had fundamentally transformed.
The aggressive, chaotic, hemorrhagic component had completely resolved.
Because the traumatic bleeding from the severe itching had simply healed.
Exactly. The blood had been masking the true pathology. Once those microhemorrhages cleared, the underlying VLS canvas was unmasked.
So the clinician looks through the dermatoscope again and suddenly sees the classic, patchy, structureless, milky pinkish areas superimposed on a whitish background.
And the diagnosis instantly pivots. They go from planning an aggressive oncological resection to managing a localized autoimmune condition.
That pivot changes the entire trajectory of the patient's life in a matter of minutes, just because they looked through the right lens.
It's profound.
But, the guidelines in our sources are also very clear that dermoscopy, while revolutionary, does not entirely replace the need for histopathology.
No, you still need the lab.
A biopsy is often still mandated to confirm the diagnosis definitively and to formally rule out any early precancerous squamous cell changes.
Right. Histology remains the gold standard for final confirmation. However, dermoscopy fundamentally changes how that biopsy is performed.
This is the mapping concept.
Exactly.
Yeah.
We established earlier that early VLS histopathology can be frustratingly nonspecific if the sample is taken from the wrong millimeter of tissue.
Right. If a clinician just performs a blind punch biopsy on an area of generic redness, the pathologist might get a sample that lacks the characteristic sclerosus.
Resulting in a false negative.
And then the patient is misdiagnosed, they're denied the necessary ultrapotent topical steroids, and the disease just continues its silent progression toward permanent architectural scarring.
To prevent that false negative, specialists now use the dermatoscope to map the entire vulvar landscape before they ever reach for a scalpel.
They are actively hunting for the most intense, active epicenter of the disease.
Exactly. They scan for the brightest, most consolidated white patches of sclerosis. They look for the densest clusters of dotted vessels or the most profound burst ice structures.
They use the optical data to literally guide the needle.
Yes. By pinpointing the absolute highest concentration of pathological features, they ensure the tissue sample sent to the lab is definitive.
So the dermatoscope acts as a targeting system.
A perfect targeting system. It guarantees the pathologist receives the highest yield sample, which secures the accurate diagnosis, which in turn unlocks the immediate prescription of the targeted steroid therapies.
The therapies required to halt the dermal fibrosis before it's too late.
Right.
It is just a remarkable synthesis of physics and biology. So, to kind of distill what we've unpacked today for you listening, when evaluating a condition like early vulvar lichen sclerosus, where the initial symptoms are deceptive, but the long-term consequences are catastrophic naked eye observation and blind biopsies are clinically insufficient.
The visual barrier of the disease demands a more sophisticated approach.
Specialists are wielding dermoscopy not merely as a magnifying lens, but almost as a time machine.
I love that framing.
They are using polarized light to pierce the stratum corneum, actively hunting for the fleeting vascular fingerprint of dotted vessels. They're looking for the comedo-like openings and the burst ice structures.
And they're racing against the biological clock. They're attempting to decode the skin's distress signals before the process of hyalinization fuses that collagen net into an opaque, impenetrable shield of scar tissue.
It allows clinicians to read the invisible microenvironment in real time, catching the pathology before it manages to bury its own diagnostic tracks.
And, it forces a real shift in how we think about the skin as a diagnostic medium in general.
Oh, so?
Well, the surface isn't just a barrier. It's a deeply complex communicative canvas if you apply the right optical filter.
That concept leaves us with a highly provocative thought to explore moving forward. I mean, we are currently utilizing polarized light to uncover the hidden, localized universe of an inflammatory condition like VLS.
Right.
But it forces the question, What other systemic, deeply internal conditions diseases we currently struggle to identify in their earliest, most intervention-friendly stages are secretly broadcasting their microvascular or structural clues right on the surface of our bodies?
Just waiting for us to look at them through the proper lens.
Exactly. A completely new frontier in non-invasive diagnostics. That is something for you to think about. Until next time.